I'm Cameron. I'm a fourth-year med student at University of South Carolina. This is our project on the impact of hypertrophic obstructive cardiomyopathy on sepsis outcomes. Um, the point of this project was to kind of better characterize the risk stratification in septic patients with underlying heart failure. What we do know about sepsis and heart failure that's been documented in the literature is that reduced ejection fraction have a higher mortality with sepsis when compared to like preserved ejection fraction, likely due to the complexity of adequate fluid resuscitation in a patient susceptible to fluid overload. And while that like makes clinical sense and has been well reported in the literature, the impact of sepsis on hypertrophic obstructive cardiomyopathy has been left unexplored. I mean, literally, when we typed it in PubMed or any search engine, kind of nothing really came up on that, probably because HOCM is rare. But so that's what this project is about, is a retrospective study looking at the impact of HOCM on sepsis outcomes when compared to other heart failure subtypes. So we did, sorry, I moved my mouse. We used patient records from the NIS database from 2019 to 2020, identified patients who were admitted with sepsis and who had a history of preserved ejection fraction, reduced ejection fraction, and HOCM using ICD-10 codes. And then we found that around 330,000 patients were admitted with sepsis. Around 30,000 of those had reduced ejection fraction. Around 35,000 had preserved ejection fraction, and only around like 250 had hypertrophic obstructive cardiomyopathy. Our main outcome that we were looking at was the mortality difference between the groups, and we used Z-scores to identify that. So in this center graph, the first column is the proportion of patients who admitted with sepsis, that like 330,000 number, and the pink at the bottom is the number of patients who died. The second column is those with sepsis and preserved ejection fraction. Third column is sepsis and those with reduced ejection fraction. And then the final column is sepsis with hypertrophic obstructive cardiomyopathy. And again, the pink is those who died. So as you can see in the third column, and kind of as we predicted and as the literature showed, the mortality rate of those with sepsis and reduced ejection fraction was significantly higher across all groups. And when compared to preserved and compared to HOCM, they were significantly higher. When looking at the sepsis with preserved ejection fraction and with HOCM, there was no significant difference in mortality between those groups. And surprisingly, the group of sepsis and hypertrophic obstructive cardiomyopathy, the mortality between that and compared to sepsis alone, there was no statistically significant difference. So kind of what we found was when these patients were admitted for sepsis, those patients who had HOCM had similar outcomes to patients with preserved ejection fraction, both of which had improved mortality when compared to the reduced ejection fraction group. And kind of like how I said at the beginning, this was all to better risk stratify those with sepsis and heart failure for the clinician to, see that in a broad view. So hopefully, this adds to the literature that the mortality for reduced ejection fraction is higher in sepsis, and now adds something new to the literature that there was no really difference in mortality with sepsis and HOCM compared to other heart failure subgroups. And then my references are down here, and we have no financial disclosures or anything.